Hi, this is Dr. Eric Dein from Rheumatology in Summit, New Jersey, and I'm delighted to be here at the end of ACR Convergence 2023, recapping with RheumNow some of the great sessions that we had. And I'm fortunate to be here with Dr. David Wu from Johns Hopkins and Johns Hopkins Bayview. Um, Tell me, so you did a great session on Sunday afternoon about your role as a palliative care doctor and how that fits in with rheumatology. And I think for some rheumatologists that may not be intuitive. A lot of us take care of. We want to treat our RA patients and get them back to playing sports and be active. Tell me, what is palliative care and where does it have a role in some of our autoimmune diseases?
Yeah, great. Thank you so much. Pleasure to be here, Dr. Dein. Good to see you. So palliative care is an approach to care for folks with serious illness and really focusing on quality of life and on symptom management. And ultimately, a lot of it is making sure that the care matches what's deeply important to our patients and our families. A couple points to emphasize are that palliative care is not equivalent to end-of-life care and hospice care, even though sometimes it gets conflated. That palliative care really can get involved at any stage of serious illness, and that end-of-life care and hospice care is a subset of palliative care. So that's one thing. And the idea is that when we take care of folks who have serious illness, meaning illness that seriously impacts our patient's quality of life and or causes a lot of caregiver stress and has symptom burden, that ideally it's a continuum of care. So the more advanced the illness gets, the more the proportion of care should be focused on quality of life and palliative care, whether that involves a specialist or it's the primary palliative care being given by, say, a rheumatologist. And the last thing I'll say is that with rheumatology specifically, if you think about a lot of the diseases that rheumatologists treat, such as vasculitis, lupus, and inclusion body myositis, that these are diseases that by and large that don't have a cure, that tend to be progressive and definitely fall under the category of serious illness. And therefore, I think likely a large proportion of patients with rheumatologic disease could benefit from palliative care.
Mhm. Yeah, I really liked in your talk how you gave kind of that diagram that you showed me before of it's not just curative care and then palliative care. It's kind of a ramp that as you're increasing some of these palliative strategies to treat the symptoms while maybe taking a little bit less of an approach with the curative as disease sometimes progresses and that it's not an either or. And really, I think one of the things that you said is really just addressing it early on in the relationship. Can you talk a little bit about how someone who's not a palliative care specialist, when I should start to be talking about this?
Yeah, I would love to address that. So just to make sure I'm being clear with my terms, when I'm talking about primary palliative care, that means the skills, the skill set that we think all providers across specialties should have in terms of having goals of care conversations, advanced care planning, talking about decisions at hand either now or in the future, and making sure that we're thinking through these with our patients so that they can make choices that reflect their deepest values, and as well as symptom management. But to get to your question, I'll focus on the communication piece because I think that's where you are aiming. I think that those kind of conversations, one way to think about them is that it doesn't have to be a big doom and gloom conversation where you're talking about end of life. Really, we're talking about quality of life. I think that's the big lens to think through this when we're thinking about early conversations for our patients who have rheumatologic disease. Let's make sure that we are not just focused on longevity, which tends to be the default mindset for many of us in medicine, right? Let's make sure that we are thinking about the quality of life of our patients and families, as well as the caregivers for the patient. And I think engaging in those conversations early, where we ask, let's say in a clinic visit, a rheumatologist could ask their patient with inclusion body myositis how daily life is going, what brings you joy, what challenges are you facing, and through that lens of quality of life. And I think that that's a conversation that could and should be had very early, and that way the rheumatologist could get insight as the disease progresses, sort of checkpoints on what's going on with the patient's functional status and quality of life, and sort of overall holistic picture.
Yeah. Um, and I agree. I think often we think of it as this daunting conversation. I think it's always been remarkable to me that when I'm worried about bringing up the conversation, how many times, I'm worried that I'm going to plant the seed of something but how many times these patients are already thinking about these concepts, and it's already in the back of the mind, or they already know, they've been living with something that they see progression. Do we know kind of what patients, what they're thinking about before they see a doctor, or how much they're thinking about, if not the end of life, but the symptom management component of it?
Yeah. I think what we don't know very much is about rheumatologic patients in this realm. And actually that's a gap that we want to highlight, that there's an area there to be explored, not just clinically, but in the research realm. But more broadly in palliative care, there's plenty of evidence supporting that patients and families appreciate being able to have these conversations proactively with their medical providers, and also evidence that they often don't, because they're concerned about how the doctor might respond, for example. So, in our experience, we often find, just like you said, that patients and are talking about this and thinking about these issues, and doing it with their families, but not necessarily with their providers, unless so all the more reason that we should be proactively, thoughtfully making sure that there's a bridge there so that they can feel free to speak about those things with us.
Mhm. Yeah, and I think during the session you gave kind of a great explanation of palliative care, and then we dug into a couple instances where we saw it, and we talked a little bit about in the field of neurology, IBM, and kind of relating that to the similar conditions of ALS, and then lung disease, and or patients with interstitial lung disease. Um, do you, when you're seeing patients of for an evaluation as a palliative care doctor, do you approach things differently based on kind of the diagnosis, or is it more kind of starting with their goals? Tell me about kind of how you approach all these different manifestations that people can have that affects symptoms or quality of life.
Yeah, that's an excellent question. Um, so I'll tackle that by starting with my general approach when I talk with a patient and family, which is to enter into their story, right? So in our talk, I talked about the 3-act model, which we designed at Bayview, and act 1 of that is understanding our patient's story, and we use literature and arts to attune our listeners to the kind of attentive listening we think they should have. So I always feel like you can't go wrong if you start by empowering the patient's voice to tell their story in whatever way makes sense to them. And all the while, I'm attentively listening for those deeper emotions, deeper values that we can then tie into potential medical decisions or options at hand. Act two is sharing the medical condition, and that's where I think the different disease conditions and having knowledge and some expertise in the way the trajectory of those diseases unfolds that's where the difference happens. And there's some famous line graphs in the palliative care literature around the different trajectories, for example, with COPD, right, with the exacerbations roller coaster up and down, but overall decline, versus say someone with dementia where it's a dwindling, constant dwindling decline. And I think keeping in mind trajectories, different symptomatology, whether it's IBM or ALS or interstitial lung disease, and keeping those different aspects in mind are, of course, critical. And particularly being mindful of the different symptoms that often are going to arise as the disease advances, whether those symptoms are there now or proactively planning for those symptoms that may be coming later. I think those are really important. And so just to finish the 3-act model, so that's act two. And then act three is that we come together and we frame the options, whether those are options at hand or future options, and frame them in terms of both values shared in act one and the medical situation in act two. So I hope that was coherent.
And I think, again, I think you did just a great job at walking through, throughout the talk. And I just want to commend you on a fantastic session that I encourage anyone listening to this to log on to. Everything's available on demand. And this session was from Sunday, November 12th. It was palliative care is a time to make room for it in rheumatology. And so thank you so much for your time. I'm really lucky that I was trained at Hopkins Bayview, where I think this was a big part of the teaching there. And I think it's something that I can think of times seeing patients with GI disease and scleroderma and IBM and these conditions where I think it is something that comes up not infrequently, and it's a useful skill set to have.
Thank you so much. Such a pleasure to see you and talk with you again.
Yeah. Thank you so much. And tune into Room now for lots more coverage on ACR 23.